Okay, folks. Sorry to interrupt the phone calls and all, but let's go ahead and get started. All right, what we're going to talk about next is what a functional assessment looks like and what I mean by that. Okay. You're probably familiar with this term, but I'm going to talk about it in detail and the way that we use it in terms of treatment for folks who are dually diagnosed. There are a lot of actually different terms that fall into this category, and so it's important that you understand a little bit about what goes into it. The couple of terms you'll hear is functional assessment, functional analysis, functional behavior assessment, functional behavior analysis. That last one is broken down into FBA often. The schools find it very important if they get to the point where they need to do that an FBA that is done. All of these are somewhat interchangeable, and are all based in the field of applied behavior analysis. That's where it comes from. And applied behavior analysis is actually an offshoot of behavior analysis, which is more of a hard research area within psychology. Behavior analysis is really concerned with looking at reliable, repeatable rules to human behavior. It's very different from the other treatment branches of psychology where we're talking about different treatment hypotheses and theories that center around counseling and so on, where often you can run into some struggles where the person may not be responding to the method you're using, and now you're kind of stuck because the method doesn't have a way to go a different direction. Applied behavior analysis is a much more pragmatic approach that is really going to look at what is and isn't working for the person. And in terms of behavior analysis, another just sort of generally interesting point is that cognitive behavioral therapies come out of the field of behavior analysis as well. And our work here, when we do a functional assessment, is that we start with the assumption that most behavior is functional or purposeful. The person has a reason for what they're doing. Now, typically, if we are at the point where we're doing a functional assessment, we've had a hard time understanding, at least just by watching, what that reason might be, or we wouldn't be doing the assessment. But we're going to work off of the assumption that most behavior is functional or purposeful. It achieves an outcome for that person that they're looking for. It's going to focus on objectively defined target symptoms and behaviors, and I'm going to talk about each of these in more detail. We're going to incorporate the use of structured data, collecting information on target behaviors, and we're going to assess the information that we collect looking for patterns in antecedents and consequences. We're going to follow an ABC model. And ultimately, we're going to reach a point where we do treatment designed around skill building and use that structured data for treatment evaluation. We're going to talk about that quite a bit towards the end of our talk today. Okay. So a concept everybody's familiar with to some degree. Okay. So let's start out with what we do with objective target behaviors. And what I mean by that. Here, when we are doing our assessment with folks, we are going to be looking at clearly defined symptoms and target behaviors. And when I say clearly defined, what we mean is that we are looking at things that are observable, measurable, and specific. Observable means that it's something that people can directly detect in some way. They can see it, they can hear it, and they can measure it, they can count it. How often it happens, how severe it is, observable and measurable, and specific. We're going to discuss what it looks like, and we're going to discuss it in a way that if I explain it to you, when you see it, you will know exactly what I was talking about. We all know that we're on the same page about the thing we're talking about. And to that end, when we're talking about these behaviors and symptoms, we're going to have written definitions, and we're going to make sure that observers have access to our written definitions and that they're trained to competency so that we know for sure when they are seeing these things and writing down that they're seeing it, that they're seeing the same things that we were talking about. Does that make sense? So what that means is when we're talking about somebody who is presenting with behavioral concerns, instead of spending a lot of time talking about what the underlying mental health conditions are, we're going to look at the actual things that we're encountering that are an issue for that person, and we're going to make sure that we all understand what that looks like and how to record it, because that's the next step. Okay? It means taking things and looking at them and talking about them a little differently. If you've got somebody that is flying into rage attacks and is going after the people that they live with, okay? That's one way of describing things. But if I say to you rage attacks, and I ask 3 or 4 of you what one looks like, I am very likely to get 3 or 4 different presentations of what a rage attack looks like. Okay? Some of you are going to talk about hitting and kicking. Some of you are going to be talking about yelling and screaming. Some of you might talk about somebody throwing themselves on the ground. And with those different presentations, it's hard for me to know what we're talking about. So we're going to take something like that, and instead of saying that, we're going to go through and say something like this. This is often how we will define physical aggression, for example. Any intentional behavior, successful or not, that could cause harm to others. This is an objective definition. We do the same thing for other behaviors. And there are a couple of things about it that I want to point out that are important. The first part, any intentional behavior, and this is what we do when we're going through and training folks to competency. Intentional behavior means it's something the person clearly meant to do. It's the difference between swinging at you and hitting you as opposed to bumping you in the shoulder, passing you in the hallway. Right? The second one is accidental. It's not intentional. Any intentional behavior, successful or not. And this one's more important than you might think. Successful or not. That means that we record it. If I come up and I try to hit you, and you duck, or you step back, we still record an incident of physical aggression. You don't get bonus points for lack of competency at your physical aggression, right? And the reason that I say that part's important is because I can't tell you the number of times that I have started a new consult, particularly in homes where I am working with athletic young men as staff, who will not write things down because you didn't get me. I was able to avoid it, right? That's great. And the 40-year-olds coming in on the next shift who aren't nearly this quick, they're going to be real thankful to you for having avoided that. Right? So successful or not, and then that could cause harm to others. So this allows a little latitude for the person who does a playful slap against the shoulder and things like that, which is an intentional behavior that's successful but couldn't cause harm. We're going to talk about this and make sure that we're all on the same page so that if our problem ultimately is physical aggression, we know how often it's happening and we can record it in ways that we're all on the same page. Does that make sense? So this is where we start. When we're doing a functional behavioral assessment, we're going to define each of the things that we're assessing and looking at. Okay? And once we've got that out of the way, we're going to set up structured data collection. We're going to collect information. There are a variety of different ways and options for doing that. There are interview forms. There are semi-structured interviews. There are paper and pencil things that we can fill out. We can do time samples. There's a lot of ways to collect information. But when we are doing an initial assessment, we want to collect information ideally in an antecedent behavior consequence format, an ABC format. And if we can do that in a way that gets us other information like time of day, location of event, etc., that's great too. And I have an example of an ABC sheet here. Certainly isn't the only way that you can do it, but this is one example of it. And this is what we use most often in most settings at Forest City. Our antecedent behaviors and consequences, this is antecedent behavior and consequence. And so what we have here is separate sections for this. If you've been working in the field at all for any length of time, you probably remember these as 3 empty boxes. If you've done ABC sheets, the 3 empty boxes where you write in the A, B, and C that happens. You see that I don't have 3 empty boxes here? That's because what I've found when we do that is that what we get is things like, in the kitchen, hit me, told him to stop. Over and over and over and over again. And then you usually have one staff person who writes a novella here, right? But her experience is not necessarily representative of the whole group, but she's now used 4 pages worth of paper. So what we've done is gone through here, and again, this isn't my idea, this is something we borrowed or stole from other folks, but these are a series of things that may have happened before, a series of things that may have happened after, and we specify the behaviors that we're tracking. And on another sheet, there's actually the written definition for people to refer to. Okay? And then the different sections do different things for us. Right? We've got our ABC up there. In the behavior section, you'll see, and you'll see in the other sections as well, that we also have, we're going to load in the behaviors that we're trying to teach. I forgot that I had all this up here before I said all of it. We often include a severity rating. What that does for us is for behavior that's not happening very often, or for behavior that happens an awful lot. Either way, it allows us to gauge how big of an issue it is. So we know if they're only doing it 2 or 3 times a month, but it's a 3, we've got an issue here even if it's not happening a whole lot. Okay? We've got our antecedent and consequence sections with all sorts of specifics, but then each section also has an other. And under the other, we indicate specify on back. There's a section on back for people to write all sorts of additional stuff so that if they're seeing behavioral issues that we haven't identified for them, they can write them down and describe them for us. Also, I frequently see people who will check off the other to explain in more detail what they meant by something they saw there. And that's great too. That's for that person who used to write the novella. Gives them a way to express some additional information. And then this sheet does a couple of other things for us. It gives us date, start, and stop time. It lets us look for patterns to time of day. It has a location section. We actually specify the amount of time that has to break between incidents so that the staff who are doing recording know if an incident stops and they start again. If that break is 2 minutes or longer, it's a new incident. If it's less than that, it's a single incident. All of this is meant to make sure that we're all on the same page about how to record information. The more detail I can give when I do the initial training on this, the more sure I can be about what the people are telling me when they record this information. Okay? We have a location code that lets us identify if things are happening in different parts of the home, and so on. And then the last thing that we have on here, I think this is the last thing, is the no problems section. What that does is they're expected on each shift in residential settings to record if they saw no difficulties on a given shift and on a given day. So on a 30-day month, there should be 90 entries if the person had no difficulties. The reason that that is important is because with that, I know that no data actually means no problems, not we forgot to write. This data sheet, by the way, is available on our website, and it's freely available if anybody's interested in using it. I just show this as an example of how we collect information for a functional assessment. And we're going to take that information and put it together and use the functional assessment to tell us a couple of very important things in general for behavioral treatment, and these things are specifically important for working with somebody who is dually diagnosed. The very first thing that it's going to tell us is whether a behavior is purposeful. And the reason that that is important is because purposeful means rational. If I have a reliable, repeatable pattern to why I do things, odds are there's something rational and sensible about what I'm doing. So I am probably not delusional and confused about how the world works, which is very important when we're talking about an array of different mental health diagnoses. It can also tell us some things about why I'm doing things in terms of what I'm achieving from it. So, for example, if every time you come into, if I have a problem with self-injurious behavior, I hit myself, and we're wondering if this is OCD, if it's depression, if it's something like that going on that I'm not happy about the way things are working around me. And we put this data together, and I find that it is frequently preceded by somebody coming in and telling me to do something. And it is frequently followed, most of the time, by them going, oh, sorry, never mind, take a break. Now I have a behavior that makes a heck of a lot more sense. You come and tell me to do something, I hit myself, you go away. What's the purpose of that behavior? Escape. I want to get out of something. Is that rational? It's perfectly rational, isn't it? It's not the world's best way to get out of things, because I have to hit myself, but I am repeating it. Why? Exactly. And that's the way that we think about it. This is something that works. If I have no verbal skills, it may be the only way I've ever figured out how to get you to go away. And if I have verbal skills, especially for folks who have been in long-term residential placement, it's a clear indicator often that I might know how to tell you to go away, and you don't listen to me. But you listen to this. That also then begins to give us information about the role of the environment, the things around me. It gives me a direction for treatment. Now I know what I can do for behavior treatment planning, and the data that we're collecting provides information that we're going to use a little later on for evaluation. Does this make sense? We could spend more time on this, but if we're in a good place, I'll go on to the next part of what we're talking about. Do you see how this has a role in assessment and how it changes what we do? If it's clear what the purpose is, the role of mental health symptoms becomes quite a bit more questionable, right? Secondarily, it doesn't mean that mental health symptoms can't be a component of what's going on, but how we look at it becomes a different thing. For example, the example that I gave you, if that's something that comes and goes regardless of the staff that are around me, if sometimes I really hit myself and make you go away and other times I'm willing to comply, if that happens in groups over time, regardless of who's working with me, now I would actually start to wonder about depression, because I have an unwillingness to participate in things, and the only way that I can express that to you is, so what we would probably do is look at, okay, can we set up a treatment plan to teach me to say no successfully so I don't have to hit myself anymore? Now we have the real possibility that we're going to do that, and that's going to be really good, and now I'm not going to work or doing anything else anymore because I know how to say no, which is frustrating for folks working with me, almost certainly. But then that tells me that I wanted to get out of these things, and now we can look at what that looks like in terms of mental health treatment. Does that make sense? So now maybe it's now that I know that you're not hitting yourself anymore and we don't have to contend with that, but you don't want to do anything either, now maybe it's time to look at treatment for depression as well. And there are a lot of different examples about how that works and how that goes together. But doing this process is how we get there and how we understand what's going on. So this becomes, when we do our assessments, this becomes a very large part of what we do. And it requires a fair amount of upfront work. We have to train the staff in the target behaviors. We have to train them in the data collection systems. But once those things are in place and they understand how to do it, that data collection yields both the assessment information that we're looking for, it yields it in a way that allows us to see what's going on around the clock instead of being focused on a 15-minute interview or a brief observation, and it allows us to see how things are doing with the treatments that we do. And I'm going to talk about that a little bit more later. Okay. With all of this, I want to be clear that there is still a role for psychiatric diagnostic interviews. They're going to be most appropriate for higher functioning clients with intact verbal skills. So this is a part of the treatment, the assessment plan, but it's always going to need to be supplemented with other assessment information. And that's going to be true for everybody you work with, I think, regardless of what their functioning level is. You are occasionally going to have people in the mild range that just go to their psychiatrist and do just fine. And I'm certainly not suggesting that you have to do extra stuff for them. But for everybody else, honestly, I think this is the way to go. So this is how we get to assessment. Let's talk about how we evaluate and how we work with the treatment. Once we've started this process, we actually go through then and we use a scientific approach to treatment. We do this in a couple of different ways. Where we can, we're going to use research-proven and repeatable techniques. Where we don't have that, which is often, we're going to use the consensus guidelines that I talked about. I'm going to talk about those in a little bit more detail here. And a couple of other key things. Wherever and whenever possible, one of the principles that we try to follow when we do our treatments is to do one intervention at a time. This is a challenging thing often to get implemented, and everybody has to be on the same page. But when I say one intervention at a time, I mean this as explicitly as I can. I mean one thing at a time. If the psychiatrist is changing medications, we ask him to change one medication at a time. If we are going to do a behavioral intervention, we don't change the medications at that time. If they're going to move to a different room or a different home, we hold the other things that we're going to do so that we can see in each and every one of those cases what the impact of the variables we can control is. Does that mean there won't be things out of our control? Absolutely not. Always that's going to happen. But we look at what we're going to do. And it also means with our psychiatry staff, sometimes talking with them about, they'll say, well, he's not responding to the Prozac, so I'd like to switch them over to lithium. So I'm going to pull off the Prozac and we're going to start them on lithium. What we would ask them to do is start the lithium, period. We're not making medical recommendations. We're asking them to make changes in a way that we can track the impact of the different interventions. If they get much better or much worse with that change, particularly if they get worse, then is it a side effect reaction to the lithium or difficulty coming off of the Prozac? We don't know the answer to that. We won't know the answer to that. If we do each of those things separately and watch, we can know what their response to it is. And given how confusing the response to medications for our folks often is, even if the psychiatrist doesn't believe there's any reason not to do it, I can name 12 cases where they told us that same thing and it turned out, the way that we usually talk about it is that somebody forgot to read the treatment profile for the medication to the client. They didn't understand that they weren't supposed to have this reaction to the medication we gave them. Yes?
What would be the time span between taking them off of the Prozac and then putting them onto the lithium?
The general answer to that question is that's a good reason to have the pharmacist as a part of the team. Those medications, for each medication there are differences in how long the changes take to make. Lithium's pretty quick. Prozac takes a long time. I'm not a pharmacist. I'm not a physician. I only know those from talking to the pharmacist over and over because these are common medications that we use. Each of them have different profiles. And so having them as a part of the team, talking about the things that you're going to do instead of just jumping in and doing it right away, talking about different ways to look at it, those are all important components. When we have kids who take medicines for hyperactivity, for attention deficit disorder, if they're taking Ritalin or Adderall or Dexedrine, we'll often give them weekend holidays. And we'll measure the difference between the weekend and the weekday in a controlled way because those medicines take 4 or 5 hours to get out of your system. Okay? Having the pharmacist as a part of our team allows us to understand that and know ways that we can evaluate. The reason that we do the weekends for them is because then we don't have to contend with the vagaries of what's going on at school. We can just know with the things that we measure. We'll then compare one weekend to the next, on and off, and so on. But we're doing one thing at a time, each time, so we know what's going on. It's a simple concept. Often challenging to get implemented. There's no two ways about that. Especially when you have treatment professionals who, they've got 15 minutes for you and they don't want to talk about all of these details, but it's a very important component of it. And it's not a component I made up. This is a part of the consensus guidelines. The other thing that we do is we do what's called data-driven treatment. Once we have defined those target behaviors, those symptoms, and we've started to collect information on them, we have information about how often they're happening now, and we're going to use that information to evaluate how they're doing with it. I'm going to show you a couple of examples about that down the road. And we can do that with all of the treatments we do. Whether it is a medical treatment, a psychiatric treatment, a behavioral treatment, we can look at how all of them are affecting the thing that we are trying to treat. So you know that it's not just me. These are the things as they appear in the consensus guidelines, and I encourage you to go and look at them in more detail. These are just some key points that I pulled out. For medication treatment strategies, what you will see, actually in this language, in the guidelines, start low and go slow. That's a reference to dosing strategies. You don't want to start at a high treatment dose. You start in very small doses and then make changes very slowly and carefully. The consensus guidelines recommend that you keep treatment regimens as simple as possible. Okay? They want you to use the same type of dosing or less than you use in the general population. They want you to avoid frequent changes and avoid using multiple medications in the same group. Okay? That's called polypharmacy. There's a couple of different ways that's defined. Generally speaking, they advise against using multiple medicines from the same class, right? That's 2 antipsychotics, for example, 2 antidepressants, 2 anticonvulsants for behavior treatment. And as a general rule, since they'd like it to be simple, they'd like you to avoid using multiple medicines from different classes. They want it to be as simple as possible. And they recommend avoiding long-term uses of things like this, like Valium, like Ativan, like PRN meds to control behavior. These are all in there, and they're in there in detail, talking about what to do and why to do it. Okay. And again, I encourage you to look them up. I also encourage you to make them available to the psychiatrists you work with if they haven't seen them. Okay. A couple of other things I'll mention with respect to this. They talk about, and then I stole this from the presentation of a colleague, this in the next page, Dr. Kouros, who works with us often doing blended treatment, behavioral and psychiatric treatment. He put together a list based on the guidelines and his own experience of things that are usually responsive to medications. And you'll see here that he's listing behaviors, not necessarily symptoms, although some of them can be. But these are just things that generally will respond to medicines. And the reason that this is important is because it's important that we all be aware that there is actually an understanding that not everything is. These things can be done as a conjunction of other treatments, whereas these things generally are not. These are a little bit smaller, so I'll read a couple of them for the folks in the back, right? Non-compliance, complaining. Wouldn't it be nice if there was a medication for complaining? I have some people who, I'm not referring to clientele, you understand, just some people that I'd like to give that to. Teasing and yelling, sexual activity or public masturbation, which is not an uncommon thing for us to see treatment asked for, yes? It could be, but probably not by itself is it something that we would. For example, that's a good question. Let me talk a little bit about what I mean. You've all probably worked with folks who, when they talk to you, they come up and say, did the Cubs win today? Every day when you talk to them. And you say, didn't see the game today, Bob. You say, well, I hope they win tonight. Preoccupation, same thing over and over and over again. That's what we mean here. Now, my interpretation of that usually is that Bob, for want of a better name, wants to talk to you. And this is about the only topic area that he has any mastery of. Okay? This is actually probably the same sort of thing as that bypass in the hallway where you say, how you doing? Right? It's just a social contact. But we will start to look at that often and say, well, he's talking about the same thing over and over again. I'm tired of talking about this. It's a preoccupation. Why can't we do something about that? Well, that's not a mental health symptom. Now, if I'm spending all day, every day, organizing all of the stuff on my shelf, that's going to start to look more like obsessive compulsive disorder. Yes?
I know people are having a hard time reading some of the slides, so we are going to email them out to folks.
Sure. That's fine. This will probably end up on the website as well. Yeah. A couple of other things here. Attention seeking will show up. Running away is not something that we often can treat directly with medicines. Threatening people. Swearing, although I know parents that would like that to be the case. Toe walking. See the folks that you work with that are up on their toes all the time. And one of them that is, I often see people trying to medicate for, pica. Everybody familiar with what pica is? There's not a medication treatment for this. I will see folks try and treat it as OCD, and it doesn't usually turn out. In particular, we wouldn't expect these things to work very well in and of themselves. These are all things that we can do behavioral treatments for and often have some sort of success. And that was the other thing that I should mention. Now, I should say that it's not entirely impossible to treat these things with medicine. There is one way that it can be managed. With the sufficient dosing of something like a typical antipsychotic, we could get all of this to stop. And you've probably seen that too. But typically we're getting almost all behavior to stop at that point. The reason that this is important is because if we understand that some of these things are not likely to respond, that we are going to have to do other treatment avenues, if we understand it and if the doctors that we are working with understand it, then we can be sure that we are not pushing things to the point where we are medicating people to the point of obtunding them with a sedative. If that's the point that we're getting to, if we're trying to address these sorts of things, then it's probably time to look at other avenues. The other thing that the consensus guidelines clearly recommend is, as we talked about for assessment, integrating medication treatment with psychosocial interventions. And that's all sorts of different things. Environmental strategies, education for family and staff, and the people receiving treatment, behavioral therapy based in ABA and functional assessment, skill training, and making targeted behaviors ineffective are the two components that go with ABA-based stuff. You talk about that just a little bit more. So environmental strategies really means looking at the things that are going on around the person and making sure that they're not having a role in what's going on. Education is important as well, and they can work kind of together. For example, if you have somebody who really likes music, they like listening to music in headphones, they like to pace around and sing when they're at the home, and you take them out to a concert in the park. And they start having they start screaming and yelling and pushing people and running away. I have worked with folks who will then tell you that we need to be able to figure out a way to get them to make it through the concert in the park. Now, based on just the description I gave you, what condition does that person likely have? I'm pacing, I'm singing to myself, I don't like people being around me, I don't like crowds, I don't like the noise. Sure. Maybe where we need to start there is some understanding amongst the people working with them that this is not a condition that is going to be well treated for that issue. That in fact our environmental strategy should be what in that case? Say it louder.
Change the environment.
Well, okay. And in particular, are we going to go to a concert in the park? Right. That's exactly it. But it's amazing how often I will see that done. We're all going. He's got to go. No, he really doesn't, and it's probably not a good idea. And if you're on a home where everybody always goes to all the group activities so that he has to attend these things, he's not a good fit for that home. Right? He probably needs to live in a different place. He may need a different environment, and the folks working with him may need to understand that he's going to have differences, and they need to understand what those look like. And then we're going to integrate always, when we are treating with medication, there should always be an ABA-based behavior treatment plan. And the two things that you should see as a component of that, in general, for an ABA-based plan, is that we are teaching new skills. Too often, behavior modification approaches really just focus on trying to eliminate the inappropriate behavior. And that really should not be the focus of the plan. Once we have done a functional assessment, that should tell us what the skills are that the person needs. Okay? If it doesn't, we haven't done our job right. And I can't be more clear about that. If I'm engaging in a behavior to get away or to get out of something, and it's not something that we can just make not happen, then I need an appropriate way to tell you no. If I'm engaging in a behavior to get you to come and spend time and talk to me, then I need a more appropriate way to get that, or maybe I need to be on a house where everybody's not so busy that they can't talk to me. But there are ways that we can teach to get those same outcomes so that I can get the thing that I'm looking for. Okay? There are other older approaches that we use. There's all sorts of, and many of you have probably been trained on different behavior modification approaches, where we're going to say, offer Bob, who hits himself when we ask him to do things, we're going to offer him a pop if he does the things. And some of that can work, but the pop has to be more important to Bob than us going away. If we can teach him just to say no, he's going to learn that a whole lot more quickly. Because it's actually getting at the thing that he wants. And a well-designed program will do that. Also, often our program also has to make the existing maladaptive behavior, the target behavior, ineffective. We have to make it not work. And the reason for that is because if we don't, we often stick with what we know even when something new is offered. Yes?
This may not be the right time for this question, but as I'm looking around the room and the professionals that are, you talk a lot about what we can do if we're working in group home settings. I mean, the functional assessment and things like that. If you have somebody in a group home, you see the behaviors on a daily basis.
Yep.
If you have them in a day program, you see them on a daily basis. But I'm looking at the nurses and
Sure.
some of the case management folks. These are people that are seen once or twice a week that tend to be very, how I want to put this politely, politically correct. They're high maintenance.
Yep.
In some cases. So how can we take some of these strategies that you talk about today, the person we see once or twice a week?
There are a couple of ways that you can do that, and that's an excellent question. What we'll be doing with those things, and it depends on the situation. If we can identify people who work with them routinely, we will train them to competence in the type of information collection that we're talking about. And we will work with them on that. When I go in and I do a consultation for this type of work, I can't be there all the time. In fact, often, based on my schedule, I can be there maybe 2 or 3 times a month at best. So I'm relying on the folks that are around them regularly to give me information about what's going on. And you're right, I'm mentioning staff, but parents can be trained to do this, and often we do that. If they have family members who are not parents that are living with them, we can do that. If they have aides, we can do that. And people who are working with them routinely can be used to do that. If that's not available and we have something going on that we're struggling with respect to that, there are actually more targeted measurement approaches that we can use to perform the same functions. There are a couple of different measurement types, like time sampling, that we can do, where we will measure the same period of time repeatedly over the course of a period of time. So we might go in on every Tuesday and Thursday at 2 in the afternoon and measure for an hour. And we'll use that as our comparison technique. As we work out from these things, they become less precise, but they're still usable. When I have staff that have a difficult time wrapping because they're poorly staffed or their staffing ratios are low, I will often give them just a shift rating sheet where at the end of the shift they record how things went in an objective way, and it gives me something to begin comparing and looking at. If I have a person who has a very high frequency behavior and and it's amenable to this, and it's not a super high risk behavior, we can actually do what's called an analog or an experimental assessment, where we go through and actually directly induce the maladaptive behavior under controlled conditions to see what conditions it shows up under. Now, these last couple of items obviously are going to require somebody with more specialized training. However, the state does maintain a list of behavior analysts that will work under the Medicaid waiver items and so on, and the Behavior Analysis Certification Board maintains a nationwide listing that you can do regional searches for, and that's the sort of person you'd want for things like that.
Get that list, and do you take those rates?
I do take those rates. The list is, you will want to talk to your network facilitator. They should have it. And I'm sorry, you were going to ask a question and I skipped past you. Okay, good. All right. That's an excellent question. Other questions in that area? Good.
What I was going to ask is if it's in a group home and they're, not supervised at all times, if they could help each other if they see behavior and maybe.
When you say they could help each other, what do you mean?
Well, like if they're very high functioning and one of the people is having problems with behavior or something, they can help each other, or like let the group person know, is there a way to do that, or do they not, or do you not?
I have not done that. I don't know that I've had anybody that I thought was reliable enough to provide that kind of a measure. That would be my concern. You might, if somebody's being really bugged by the roommate, you might find somebody who is motivated to do it, but then I'd also be concerned about conflict of interest on the data recording.
That's what I was thinking.
Bob was mean to me 423 times this week, and he needs to move. which might also be written on the data sheet. But I have even done for things like that, situations like that, where we have no other way to gather information. If we can get everybody to agree, we'll set up cameras and actually go through and look for very short periods of time so we can see what's going on if there's no other way to gather the information. But there's almost always a way to get these kind of measures done and get the information that we're looking for. The next question is, how do we evaluate what we're doing? And there are a couple of things that the guidelines talk about explicitly. One is that we collect a baseline before beginning treatment. You probably all know what that means, but I'm going to say it anyway just to make sure we're all on the same page. A baseline is a measure of how things are doing before we do treatment, right? When we first go in, this can be kind of a struggle for folks because we're saying, okay, we're going to collect information for a few days, a week or two before we try anything, and then that can be a struggle because they'd like you to start helping now. But we need to know how often things are happening. Sometimes when I do a baseline, what I find is that they're not happening nearly as often as we thought, which can be informative. But we need to know how often they're happening before we begin treatment so we have something to compare against. And then the consensus guidelines recommend just exactly what we've been talking about, that we're going to examine efficacy of treatment by tracking against specific target behaviors, okay, using recognized measurement techniques. And our ABC sheet is an example of that. That's a way that we're going to measure it. So what you should see when we do that is that people begin collecting information, and we start to get things that we can count about how often things are happening. We get patterns so that we can do our assessment on either side. We have times of day so that we can see what's going on. But even after we get treatment in place, this part continues to be important because it tells us how often things are happening. And once we have that sort of information in place and we are doing our treatments, we can use that to evaluate how we're doing. And we do it in a way that looks like this. This is a behavior graph. It's a behavior graph for a young man with autism. And I'm going to tell you a couple of things that you see here. You've got, of course, all sorts of lines. We're tracking this data in the cases that I'm using today by month. And we're tracking verbal agitation, physical aggression, and property destruction. This young man, when we started working with him, was on 4 different psychotropic medications, including Ritalin, Risperdal, Buspar, and Prozac. And what you see here is these are what we call condition lines. They are changes in what we did with him. And I use this as an illustrator. I did not make this up, but I use this as an illustrated example because you see that we have one line after which everything seems to get a whole lot better. Okay. Now, one of the nice things about presenting information this way is because you can see things like that, right? We can see what's going on in a direct way, but then also we can see what happened with it. This, in case you can't read it, says that in June of '06 he began at Willow Glen, which in his case was a specialized school for children with autism. Now this is data from home, not from the school. Okay? But he began at a specialized school for children with autism. These other changes are changes in medicine. Here we held on to Ritalin, and here we discontinued it. We held it here back on the 6th of May, and May looks a lot like the months before that. Held it means we didn't stop the prescription, but we didn't give it to him anymore. And he was fine. Now there's a bump up here which seems to go with us discontinuing Ritalin, but remember earlier I told you that one of the things that we know from talking with the pharmacist is that if you stop taking medicines like Ritalin, it's right away. We would have seen it back here. Something else is going on here, but it's not due to that medicine. So you see how that combined information begins to tell us what's going on. Here we adjusted a schedule and decreased Buspar, and everything looks more or less the same except for a different month here. And then he started to attend school at Willow Glen, and everything gets a whole lot better. Now this guy's in the mild range, and he's got some pretty impressive verbal skills for a person with autism. And back here or so, he said to us, "I don't think my teacher at school likes me very much." And it turned out his teacher at school didn't like him very much. And now he is at a school where the staff are educated in the needs of a child with autism, and he's doing much, much, much better. Okay? And importantly, we can see that, and this stays in his record, so that the other people working with him 3 years, 5 years, 10 years down the road can also see how he responded to things. Now, the other things that you see here are changes in medicines in this case, where we are reducing Buspar, which is a medicine sometimes used to treat anxiety. And what is the impact of reducing Buspar? It's doing nothing. And so we know within this inherited regimen that at least down to 30 milligrams, this medicine has no impact on his mental health condition. And Ritalin had no impact on his mental health condition. I think we just finally discontinued his Buspar. But we're making also one careful change at a time so that we can see that, so that we know what's going on. Now, ideally, you'd start low and go slow, but most of the cases that we get, we inherit. And so they're often on multiple treatments to begin with. And so we end up going backwards, peeling things away. But this is the way that it looks. Okay? So that's one example. Let me give you another. This is another young man with autism, but much lower functioning. And they don't all have autism, I promise. Just had to look and see. Okay, and I know you can't read these from there. These are multiple med changes. What we were trying to do was get him off of Ativan, which he'd been taking for a long time. The guidelines say that we don't want to do. And so in order to do that and to address some of his obsessive-compulsive symptoms, we started him on Zoloft. We did that back here at a very low dose, and he seemed to do a little bit better. And then we increased it, because he was doing so much better, to 50 milligrams a day and got this. And I was saying earlier how we sometimes look at this and say nobody explained to him the response he was supposed to have to the medicine. So he clearly didn't understand here that he was supposed to do twice as good as he was doing on 25 milligrams. But this is why we look at it this way, because instead of being bound theoretically, we're evaluating it based on his actual response. We end up getting rid of the Zoloft here after trying a couple of other things, and we know that that's the thing that is contributing to him having difficulties.
What was the behavior? You said it's physical.
I'm sorry, thank you. Physical aggression, the red is self-injurious behavior. This one is the actual abbreviation is standing on the head, or gymnastics. This is a gentleman who can do things like, the big therapy balls. He can actually travel around the house on them. He literally lays across it and rolls, and he'll keep it going under him. It's an amazing thing to see. But it's worrisome, and so we kind of keep track of it. Now, he's never run into anybody or anything, but that day is coming. It's an amazing guy. And then the last one is screaming or verbal agitation. Okay. And then sometimes these get really, really complicated. Yes. Now this is, understand, this is from 2000 through 2008. So there's 8 years of information on this graph. But this is a gentleman in a state-operated center with some severe issues with physical aggression and other things. What's important to see, though, in terms of looking at his treatment plan, is that here's some the orange ones are some adjustments in olanzapine. The blue one, and the black heavy line, I'm sorry, is physical aggression. The blue line is verbal agitation. We have property destruction, inappropriate sexual behavior, elopement, and SIB. This blue line is starting of a new behavior treatment plan. And this is what it looks like after that. And there's a couple of other things that you have to see here. We did reduce olanzapine to 10 milligrams, and he was fine, to 5, and everything comes up. And we went back up to, we reduced it to 7.5, then to 5, and then we go back up to 7.5, and things come back down. So we now know what the role of olanzapine, or Zyprexa, is in his treatment. It helps keep aggression down, and helps keep verbal agitation down. So he was also on lithium, so we reduced it here. I don't know why lithium is pink, but it is. And here, and discontinued it here. And if you look at the rates of the behavior during that time, we also know what the role of lithium is in his treatment plan. Does lithium have any side effects? have some very significant side effects we have to worry about over time. These are changes in the behavior treatment plan, which you did pretty well with. These, which are really hard to see here, are reductions in clonazepam or Klonopin. Yep, Klonopin. And here, I know you can't see it. I wish it didn't wash out so much. We reduced it. We got down to 0.5, and he started to have difficulty, and we put it back up to 0.75. But he had been on 1 milligram a day for about 5 years. So he doesn't need 1 milligram a day. He needs 3/4 of a milligram a day. And we worry about these things. Dr. Kouros will tell you, he tells me over and over again, we worry about these things in terms of what's called dose years, which are similar to pack years in smoking. The longer you're on a medicine and the higher the dose, the more prone you are to side effects. So our goal is to find the minimum effective dose. Now hopefully in your community settings, you won't be dealing with folks that look quite like this. But we use it everywhere from those young guys out that are more or less out on their own, right down to the very, very significant cases. And those are a couple of examples of how they work. And that all of that information that you see there comes off of the type of data collection that I was talking about. So in sum, what we want to be doing is using an interdisciplinary approach to both assessment and treatment. Get everybody involved, make sure we know what's going on. We want to clearly define our target behaviors, our symptoms, and our treatment goals and objectives before we start initiating treatment. We should know what we're doing before we begin. We want to use a comprehensive treatment approach. We want our evaluation to be data-driven. And something I mentioned briefly, but I'll touch on here again, we want to not be afraid to reevaluate our treatment hypotheses. If you have gone in with the assumption that the person has bipolar disorder and your treatment is based around that, that's not wrong unless it's not working. But when it's not working, then it's time to go back and begin this process again. And we do that, I do that more often than I would like to have to, but we do it to get us where we need to go, because if it's not working, then clearly we need a different model to follow. And where you can, and I realize you don't have a lot of control over these things, you want to work with professionals who are comfortable with a team approach and who are aware of these consensus guidelines, who are willing to work with that. A way that I might start with that is to, when you're talking with the doctors and you're beginning those relationships, is to see if they're familiar with it, if they're willing to talk about it, and where you have a choice, I might use that to make decisions about whether we're going to continue to have a relationship with that person. And as I say, I know that we're often in a position where we don't have a lot of choice. Sometimes it's also helpful to make folks aware of it and sort of drop it as an idea, and maybe they'll come back to it later on. Okay. And then those are some of the links that I said would be on there, and they should be on your sheets as well. Of course, CITY is our website. The consensus guidelines you'll find at this address. It's a complete PDF of what you see there, so you can print it up for yourself. And then there's also the National Association for the Dually Diagnosed. And I'm sorry, this is a very complicated URL. Right? Any other questions or thoughts, comments? Yeah.
On the slide that lists the behaviors usually responsive to psych meds, one of the things that's listed there is impulsivity. I'm wondering if that would include the verbal impulsivity, the filter issues.
Yes.
Does psych meds help with
It
that?
does. And actually for folks, we even see for folks with traumatic brain injuries that sometimes it will be helpful with that. Can help with the filtering, which can be a real issue sometimes. But you have to look at the things that you're talking about with the assessment process that we're doing and make sure that we're talking about impulsivity. I was using the example before. If I come up to you every day and ask about the Cubs, that's probably not impulsive. If I repeatedly blurt out things that are grossly inappropriate in the wrong circumstance, that's probably impulsive. I'll leave this up. Thanks very much for coming, folks. Appreciate your time and your attention.